Good evening. I'd like to thank the conference organizers for inviting me to participate in this poster discussion session looking at novel immunotherapy approaches. These are my disclosures. And these are the two posters that I'll be discussing, beginning with the activity of atezolizumab plus paclitaxel in metastatic triple-negative breast cancer according to bursting molecular subtype, an analysis of the IMpassion131 trial. To set the stage, I'll remind everybody of the IMpassion130 trial, which was a phase 3 study that randomized patients with metastatic triple-negative breast cancer to receive either atezolizumab plus nab-paclitaxel or placebo plus nab-paclitaxel. The trial had co-primary endpoints of progression-free survival and overall survival, and those analyses are shown on the right, where you see that there was a benefit with respect to both PFS and OS for the addition of atezolizumab. Based on the PFS results, the FDA granted atezolizumab accelerated approval in March of 2019 for the treatment of PD-L1 positive metastatic triple-negative breast cancer. This was the first immunotherapeutic agent approved in breast cancer, and continued approval was to be based on the results of the IMpassion131 study. Shown here is the schema for IMpassion131. Again, it enrolled patients with metastatic or unresectable locally advanced triple-negative breast cancer. This study had a 2-to-1 randomization to atezolizumab plus paclitaxel or placebo plus paclitaxel. The trial's primary endpoint was PFS. The trial was first presented at ESMO in 2020 and subsequently published in the Annals of Oncology. And what I'm showing here is the PFS analysis in the PD-L1 positive population, and you see that there was no benefit with the addition of atezolizumab. Shown here is the overall survival analysis, and again, no benefit to the addition of atezolizumab. In fact, the placebo group did numerically better, and I would highlight the 28th-month median overall survival for patients in that placebo arm of this study. So why no benefit to atezolizumab with paclitaxel? Well, it's been suggested that it could be due to steroid pre-medication, as most patients took steroids over the entire time they were on chemotherapy. But I'll remind everyone that we saw a benefit to pembrolizumab in the Keynote 355 study to include in patients that received paclitaxel with steroids. I would also highlight the considerations related to sample size and trial design. 131 had a 2-to-1 randomization, so there were relatively small numbers in the PD-L1 positive control arm, and I've already highlighted that the control arm outperformed what we would have expected from single-agent taxane. What about the patient population? 131 enrolled a smaller percentage of stage 4 de novo patients. There were equal numbers of patients with prior adjuvant taxane, but perhaps there were differences in the disease-free interval since taxanes. And it was noted that IMpassion131 enrolled more Asian patients, which was a subgroup that had less benefit in IMpassion130. It's been reported that triple-negative tumors in patients of Asian descent are more likely to have luminal androgen receptor subtype. And in ASCO this past June, Dr. Emmons and her colleagues reported data suggesting that the luminal androgen receptor subtype was associated with potential resistance to atezolizumab. And that data is shown here. So again, Dr. Emmons and her colleagues looked at the molecular subtypes in IMpassion130. The subtypes were assessed with RNA-seq using the bursting classification. In the upper left of this slide, you can see the distribution. 27% of tumors were basal-like immune activated, 42% basal-like immune suppressed, 26% luminal androgen receptor, and 5% mesenchymal. Shown below that is the PD-L1 status within the molecular subtypes. You can see highest in the basal-like immune activated. And what Dr. Emmons and her colleagues reported at ASCO was that the benefit of atezolizumab with respect to both progression-free survival and overall survival was most pronounced in patients whose tumors were of the basal-like immune activated subtype. So the goal of the current study was to explore the prevalence and impact on clinical outcomes of the triple-negative breast cancer molecular subtypes and race in IMpassion131. This study had a biomarker evaluable population of 471 patients, which was comparable to the intention to treat population, except there was a numerically lower proportion of Asian patients and a numerically higher proportion of patients with basal-like immune activated tumors. Shown on this slide is the distribution of the subtypes in the two different studies, 131 and 130, and you can see that they are quite similar. Shown here are the molecular subtypes by race. What we noted was that there was a numerically lower percentage of Asian patients with basal-like immune activated and a numerically higher percentage of Asian patients with luminal androgen receptor subtype. These investigators looked at clinical outcomes by molecular subtype with respect to both progression-free survival, which is shown here, as well as overall survival. With respect to progression-free survival benefit with atezolizumab, it was only seen in the basal-like immune activated subgroup. There was no subtype that derived overall survival benefit from the addition of atezolizumab. Shown here is the PFS according to treatment arm, subtype, and race. And what you can appreciate that there is no subtype or race that is associated with an improvement in PFS with or without the addition of atezolizumab. And so from these findings, these investigators concluded that the subtype distribution and enhanced effect of atezolizumab in the basal-like immune-activated subtype is consistent with findings from Impassion 130. The proportion of patients with luminal androgen receptor subtype was higher in Asian patients, but they're limited in conclusions that can be drawn due to the relatively small sample size. The lack of efficacy of combination atezolizumab plus paclitaxel in Impassion 131 cannot be explained by overrepresentation of a subtype less sensitive to atezolizumab. So why no benefit to atezo with Taxol? I'm inclined to give serious consideration to the issues around sample size and trial design that I enumerated earlier. Turning to the second poster, this is from the MD Anderson group, and they looked at remodeling of the inflammatory breast cancer tumor microenvironment to enhance immunotherapy. And this was informed by findings in a clinical trial that they had conducted and reported in 2018 in JAMA Oncology. That study was a single-arm phase 2 trial evaluating the anti-EGFR antibody panitumumab combined with nab-paclitaxel and carboplatin, followed by fluorouracil, epirubicin, and cyclophosphamide in patients with operable HER2-negative inflammatory breast cancer. The study enrolled 40 patients, 21 with hormone receptor positive, HER2-negative IBC, and 19 with triple-negative inflammatory breast cancer. The trial's primary endpoint was PCR, which was experienced by 28% of patients overall, 14% with hormone receptor positive disease, and 42% with patients with triple-negative disease. In that first analysis, they did some correlatives and suggested that phospho-EGFR could be a potential predictor of pathologic complete response. So they went back and looked at the patients on this study, which I should note, there was a single dose of panitumumab that was administered 2 weeks prior to initiation of combination therapy, which gave them the opportunity to do some correlative studies looking at the impact of the panitumumab on the microenvironment. What they found was that for patients that experienced a pathologic complete response, that additional dose of panitumumab was associated with an increase in CD8 positive T cells and a decrease in the immunosuppressive regulatory T cells, as well as the immunosuppressive M2 macrophages. This was not seen in patients that did not experience a pathologic complete response. So they took these observations back to the laboratory where they used a SUM149 humanized mouse model, SUM149 being a very common inflammatory breast cancer cell line. They treated these mice with an anti-EGFR antibody and found that the treatment altered the cytokine and chemokine milieu, which in turn impacted immune cell recruitment with an increase in CD8 positive T cells and a decrease in Tregs and M2 macrophages, much had been seen in the patients enrolled on their study. They then looked at the EGFR pathway as the regulator of this chemokine expression through EGR1. Shown in figure A is an image from their mouse model where anti-EGFR antibody led to a decrease in EGR1 expression in their mouse model. Then in the SUM149 cell lines, they showed that EGF stimulation increased expression of EGR1, that's shown in panel B, and EGR1 knockdown inhibited EGF stimulated expression of EGR, shown in panel C. They then went back to the mouse and looked at the combination of an anti-EGFR antibody with an anti-PD-L1 antibody, and what they found was that mice treated with the combination therapy had the largest decrease in tumor volume. And when they looked at the tumors in these mice, they found that those that received combination therapy were most likely to have an increase in CD8 T cells and a decrease in Tregs and M2 macrophages. So I applaud this group from taking an observation in their clinical trial to the laboratory, and they'll now be able to take this back to the clinic as they have proposed to conduct a clinical trial looking at anti-EGFR antibody in combination with anti-PD-L1 therapy in triple-negative inflammatory breast cancer. So putting it all together with these two posters, I think they show us yet again that the tumor immune microenvironment matters. This is something that we've known for a while now, with initial work from Shireen Loy and her colleagues showing the prognostic value of tumor infiltrating lymphocytes in triple-negative breast cancer, then Carsten Dankert and his colleagues showing the predictive value of TIL in breast cancer. But I think to continue to move the needle, more studies need to be conducted, much as these investigators that we've seen posters from this evening have done, where we more rigorously look at the impact of our treatments on the heterogeneity of the tumor and the tumor microenvironment, so both cell intrinsic and cell extrinsic mechanisms. This knowledge is required in order to inform future studies. I thank you for your kind attention and look forward to the Q&A. Thank you.